Sorry to make the move. Actually, I have to update my bio. I'm no longer at Centerlight Healthcare. I'm actually working with the VNA of Health Group in New Jersey. So sorry I didn't get that in sooner. But anyway, I apologize for my voice. It's not contagious. I've been to the doctor. It's all about allergies. This is by far the worst season I have ever had. But anyway, I will do my best and try to speak loudly and get through this. So I'm honored to be here today to talk about the current state of home health care. I feel like, in a way, we got to get past my presentation because today and tomorrow is about the future. So what I'm really doing here is giving you a context and letting you know about what home health is today and what we will see as changes. I will talk to you a bit about some of what is occurring, some of the challenges, and even potential opportunities. So how do I turn the slides? Really good. Okay, so staying within the context of Medicare, what I'm going to do is give you an overview of what it means to be eligible for home health in Medicare. I'm also going to talk to you a bit about what services are delivered through the home health benefit. I'll also give you an overview of the size and expenditures currently being spent on home health, mainly from the Medicare perspective. Then what I want to do is give you a sense of what traditional home care is now. We'll walk through some quality indicators and really get a sense of how good of a job is home health doing. And then we're going to talk about emerging models, things that are happening now that are new and different from what was around even a few years ago in home health. We'll talk about some challenges and potential barriers for change. I'm going to mention very briefly about what's going on in home health with respect to technology because I think that's very important to the future, and then give a sense of what the opportunities are for the future. And I know Steve Landers is really going to talk about that in much more depth. So just to give you a sense, and this is just a general overview of what the population looks like that's in Medicare today. So most of the people who are over 65 have 3+ chronic conditions. Many are living below the poverty line. Oftentimes, people at this, when you're in the Medicare group, you have a cognitive or mental impairment, and that's about 30%. This is a very challenging population. People in this group also rate themselves as being in fair or poor health quite frequently. They also have 2+ ADL deficits, that's activities of daily living. There is a population that is receiving services from Medicare that's actually the young disabled, and that's not a small group. What's astounding here too is the percentage of people who are over the age of 85. And then, although it's small, about 5% of this population is living in long-term facilities. Just think about the changing demographics. Again, this is not so much about the future, but there's been some tremendous change, and this really creates a challenge for our society and the providers in this space. Just the group of people that were over 65 in 2002 was 35.5 million. In 2012, it grew to 43.1. So it grew by 21% in a relatively small period of time. And if you look out at 2040, it's going to grow 85% over today to about 80 million people. This is really a big group of people. The 85 and older group is projected to grow from 5.9 today to about 14.1 million in 2040. And then lastly, if you do these projections out, about 29 million people over the age of 65 in 2040 will have some form of disability. Okay. So let's talk a bit about eligibility. I know this may be a little bit difficult to read, but there's going to be two pieces to this that I want you to see and understand. The first part of being in home health in Medicare is you have to be under the care of a physician, and that physician has to establish a plan of care for the patient. So the doctor or physician is in control of what is being delivered. Now, the physician also has to be sure that you need one of the following services. So do you need nursing, physical therapy, speech, or occupational therapy? So it's dividing between clinical care, that's nursing, and therapy. The person who gets the care must go to a Medicare certified home health agency. And lastly, the physician has to document that you are homebound, that you cannot leave the home, that leaving the home puts you at risk. So if you look at this, there's two major pieces going on here: the physician driving what's happening, and also that the patient has to have certain needs, both from a clinical perspective and also being homebound. So these are some of the challenges with respect to delivering the services. Now, what are those services about? Well, if it's skilled nursing, what's important here is it's got to be intermittent or part-time. It cannot be full-time care. The care should be delivered by an RN, or it can be an LPN, but they have to be supervised by an RN. And lastly, if there's going to be a home health aide, it has to supplement the care being delivered by the professionals. So we're talking about a part-time home health aide being in the home to help the nurse or the therapist. Now, if it's therapy services, again, it's the same idea. It has to be safe and specific. We also can provide social services, and this is medical social services for patients, and lastly, medical supplies. So this is the gamut of care delivery that is typically what's considered Medicare home health. Oops. I think what's important is to look at what's not covered. So it cannot be 24-hour-a-day care, cannot be meals delivered to the home, it can't be homemaker services like shopping and cleaning, and it can't be personal care like bathing, dressing, and using the bathroom if it is not associated with a therapy or nursing. Now, little caveat here. If the person is eligible for Medicaid, many times states will cover these services, but these are not traditional Medicare services. So just to give you a sense of the growth and what the industry looks like today, if you look today, there are about 12,600 agencies providing home health care throughout the country. If you look back to 2005, it was about 8,000. The growth has been pretty steady. It's been about 5.5% or so per year over time. And if you look at expenditures, what you see here is that expenditures started in 2001 at about 9.7 billion and have grown pretty steadily over the years. And if you look at 2010, that's close to 19.6 billion. So it doubled basically over a period of 10 years. It's dipped down a bit recently. It's gone down to about 18.3 billion. This is due to some changes that were made to the reimbursement system, and I think, it may continue to flatten out over time, but basically this is a pretty high expenditure service. Although, if you look at total dollars being spent by Medicare, this represents about 3%, and this is from the CBO. There are some numbers that I've seen that are higher, 5% or 6%, but this is where home health is really today with respect to dollars being spent on Medicare. So let's talk a bit about what traditional home care might be. So typically what is happening is patients are getting skilled care in the home. That skilled care is episodic if it's Medicare, or sometimes if it's Medicaid. The idea is that people are certified for a certain period of time, 60 days, and they receive care over that period of time, and then they are renewed if they need more care. It's a little different when we start talking about commercial payers. They tend to think about authorization of certain number of days of care, and they may authorize 5 visits, 10 visits. So their model is a little differently, but this is how skilled care is typically delivered. The other piece to keep in mind is that people come into home care from both the hospital, which we might traditionally think is the way, but they also come from community referrals. So physicians will often refer from the community if they feel a person will benefit from the home care services. Now, the other piece of this is to think about the non-skilled component. Patients who are receiving those supportive services to remain safely in the community. So that's more of what was not covered from Medicare for home health specifically, but may be covered in other ways, or it may be paid for privately. The idea is that it's not skilled. It's more about making sure the person is safe and can stay in the home for the longest period of time. Oftentimes, some of these people are nursing home eligible and getting those support services. The last piece that's kind of traditional today, although a lot of people may think of this one, is the PACE programs. And these are the programs that are all-inclusive care for the elderly. These programs, which are Medicare and Medicaid funded, are often center-based. So these are nursing home eligible people who go to a center, get all their health care and their services, but they do go home, and they're often supplemented by home care directly. So it's a combination of what those centers provide and what home health provides. So just kind of think about this, and some of this I've already mentioned, who's paying for these services. So when you think about skilled home care, we're talking about Medicare, Medicaid, commercial payers, the VA, managed care companies like Advantage plans. The other piece is private pay, although this is a small piece where people may supplement the skilled services by using private duty nurses. The non-skilled piece is paid for by Medicaid in some states and private pay, and then a lot of these services are paid for via people paying independently on their own to get the non-skilled. And then we talked about PACE, which is a combination of Medicare and Medicaid funding. So what I want to just give you a sense here is some of the quality outcomes and just give you kind of a thought in your mind about how well is home health doing today. So these are the nationally publicized home health quality measures. So if you were to go to Home Health Compare, and you'd look and see within your geographic area how well are home care agencies doing, these are the national averages here. And what I think, I'm going to break this up into three groups, but what's important here, this is about process. So did the home care agencies do what they should do when they're delivering care? So are they checking for depression, which is a very common sign in this population? And if you look at this, 98% of the time that's being done. Are they checking on a risk for falls? Another significant issue for this population, 98%. Are they working with the family and teaching them how to keep the person at home, how to deliver the care? They're at 93%. And how well or quickly did the team get to deliver care? So in the federal guidelines, you have to be in the home within 48 hours. Some states actually mandate 24 hours, and overall, agencies are doing pretty well in meeting that goal. Okay, these are a set of outcome measures, and the first one here, the lower the better, and this is about hospitalization rates. This is a 60-day hospitalization rate, which at 16%. If you were to go and look at Hospital Compare and see how well the hospital's doing, their 30-day hospitalization rate is 16%. So if you think about it, this is a pretty good number for home health because this is 60 days out, so the longer opportunity for hospitalization, they're keeping it at 16%. The 30-day for the hospitals is 16%. So it may not be apples to apples total comparison here, but I think it gives you a sense of what's going on in terms of outcomes. Improvement in wounds, 89%. People reporting that they have less pain, 68%, and also improvement in ADL function, and this is really about ambulation. Now, there are no other comparable data out there when you look at other parts of the industry, but if you were to look at, for example, nursing homes, and there's a nursing home compare website, you'd find there that they're really concerned about stabilization. And so that's what they talk about, is making sure or people not getting worse. But here we've got a situation where people improving ambulation, 68%, that's a pretty powerful number. Okay, and this is also an important facet in much of what you heard in the last discussion, which is what are the people who get the care saying about what's being delivered. And if you look at these numbers, you may say, well, they're a little disheartening. They're not as high as in the 90s. But these are pretty good numbers overall. If you look at the first one about would you recommend the home care agency, 79%. Well, if you looked at the Hospital Compare website, you find with respect to recommending a hospital, it's 71%. So this is, although we want this to be higher, it is a fairly high number. Also, you see that how they rate the overall care is fairly high. These are all in the 80s about how the team discussed medications, pain, and home safety, and also how the team communicated. So the overall quality, both from the process and outcome point of view and what patients are saying, is fairly good. Oops. Okay. So what are the current challenges with delivering traditional home health care today? Well, part of it is about payment. So we saw that graph about home care expenditures going down a bit. Well, overall, the federal government has been cutting reimbursement to home health, and it's 3.5% from 2014 to 2017 each year. So what's happening is there's going to be about $25 billion taken out of the home health care system in the near future. So it's a challenge for organizations trying to deliver care. The other piece that where there's been cuts is in states that have developed managed long-term care, Medicaid long-term care. They are reducing the expenditure for direct delivery of services. They're no longer paying for fee-for-service. They're now moving people to these plans that have fixed dollar amounts. And so that has curtailed the number of hours that people get, number of visits they get. And there's also been reductions in terms of commercial payers and reimbursing, as well as Medicare Advantage. There are regulatory requirements that also are challenges. Face-to-face is one of those, and this is where the doctor has to document an encounter with the patient before home health can be delivered. So the challenge here is that home health is on the hook for something they really do not control, because that conversation has to occur between the doctor and the patient, has to be documented, and then the home care agency can deliver the services. The other piece is there's a lot of scrutiny today and audits, and a lot of time and money is being spent on that. And lastly, there is fraud and abuse in the system, and I think if nothing else, this is an image problem. So good organizations are kind of trapped with respect to what's being said about other organizations. Okay, let's talk about some of the emerging models, some of the new things that are happening that go beyond what I just talked about with respect to traditional home care. So we've got accountable care organizations, we've got bundle payment arrangements, independence at home, community-based transition care programs, and where home care agencies are contracting with managed care for assessment services. So these are all new things, and what's happening is this is having an impact on home health today. And what we're seeing now is home health organizations are finding opportunities to work directly with accountable care organizations to deliver community-based care. So they're stepping out of the mold that they were in and now working with these accountable care organizations to be the community-based provider. They're also involved in these bundled arrangements where hospitals, if it's a bundle that is going to be post-acute, use both home care and skilled nursing. And what they're doing in these bundles is trying to move people to the right level of care and least costly, which has actually opened up the door for home health agencies to take on patients that might have gone to skilled nursing facilities. And also, home care agencies are getting more involved in transitional care, where they are starting to see the patient in the hospital and maybe one visit post-discharge, not traditional home care. And lastly, this idea of trying to use their assessment skills and their ability to go into the home to do high-risk evaluation of people in health plans. Now, what are the kind of the challenges to home care agencies in moving in this direction? Well, covering the cost of what they do, because home care agencies have built this infrastructure to be Medicare providers, and now they have to do things differently. Give you an example of this, a lot of software systems that were designed for home care won't allow people to document in these new models in a way that's efficient. So this is something the home care agencies have had to deal with. It's not an issue yet with bundle payments, but it probably will be down the road. Regulatory requirements. Remember, home health starts out, if it's the Medicare model, that somebody has to be homebound and they need skill. Well, if they're going to get into transitional care, that person may not be homebound and they may not need skilled services per se. So they have to change their model of care delivery. Some organizations are actually creating new entities so that they can do this, because it's really challenging for them to stay in both worlds. Competition, of course. Everybody wants to be in this space right now. And coordination. What has been said, and organizations here may want to report on this, is that when they do transitional care, they're actually going in and bumping into other nurses in the home. So you've got the hospital sending a nurse, you've got the insurance company sending a nurse. So this is really becoming very complicated, and there's a lack of coordination. Okay, so my brief talk about technology is I just want to set a tone for a couple of issues that we need to think about. So electronic medical records. So home health, kind of given the nature of the business that it's been in, has tended to be electronic for a long time, both from the idea of documenting clinical information and doing the OASIS, which is the assessment tool needed to be done in home care. Sorry. Unfortunately, meaningful use does not apply to long-term care. So what's happened here is home health hasn't benefited in any way from meaningful use. So there's no real exchange, true exchange of clinical data among providers to home care back out. And the other piece is, more recently, what I've been looking at patient portals. There are no decent patient portals in this field, but when you look at hospitals, they've been mandated to have those in the systems because of what goes on with meaningful use. So this really becomes another issue that we have to deal with. Another big piece that's happened is a lot of home care agencies are much more deep into reporting and analysis, really looking at quality outcomes and understanding how well are they doing. But again, this can be a challenge for small organizations. They have to foot the bill for it. It's not really paid for in any way. And then lastly, telehealth. This really can encompass a lot of different things, but it's video and remote monitoring and automated calls. There's a mixed literature about whether this works, but there are some organizations that show that it can be effective. The problem is if they're going to use it, it has to come out of traditional payment models. There's no additional reimbursement for using telehealth. So this is kind of curtailing really movement in this area. So opportunities for the future. As the population ages, the demand for community-based care is projected to grow substantially. The second bullet here, which I think is extremely important, and also what we heard before, patients and families prefer care at home. This is really where they want to be. The other piece that's often shown, but maybe not thought of that much, is it's the least costly of the post-acute settings for long-term care. And lastly, I think this is something we need to capitalize, and that is that home health agencies have the experience, the knowledge, and the infrastructure to support the new care delivery models. And this opens up the opportunity to bring them into all the changes that are happening today and what the future is going to look like. And so that is my talk. Thank you.